Hi, my name is Yomara Calderon Martinez. My topic is the Patellofemoral syndrome.
Patellofemoral syndrome is a very common entity. It's probably the most common overuse condition that we see in the knee. And generally people present with what we refer to as anterior knee-related pain, which is pain in the front of the knee. If we were to look at the design of the knee, there are basically three bones. There's your femur, which is your thigh bone, the tibia, which is your shin bone, and then there's the patella, which is the kneecap. So with physical activity, the patella is pulled up and down and up and down, up and down as we run. And if the kneecap stays in the middle of that groove, it's pulled up and down without any problem. If the kneecap is deviated to one side or the other, the cartilage on the back of the kneecap tends to get inflamed. The back of the kneecap is a perfectly white, smooth, shiny surface. If you look inside the knee joint, it looks like a cue ball. It's absolutely beautiful. The end of the thigh bone has that same material. In patellofemoral syndrome, people's kneecap are aligned one way or the other, so they're bearing weight primarily on one part of the kneecap than the other. So if they do a lot of repetitive activity, one part of the kneecap is working overtime and the other part of the kneecap is taking the day off. And essentially we'll start to develop an inflammation behind the patella and inflammation on the end of the thigh bone. If they have a flat foot, we'll often put them in an arch support to neutralize the alignment of the foot. More than anything, it's really a matter of retoning their quadricep. There are four muscles that control your kneecap. There's one muscle on the inside, one muscle on the outside. The muscle on the outside is generally a little bit too tight, and the muscle on the inside is a little bit weak or atrophic. If we can strengthen the muscle on the inside of the knee and work on the flexibility of the muscle on the outside of the knee, we can kind of balance that kneecap, allow that kneecap to ride in the groove that it's supposed to, and the inflammation will go away. So part of it's rehab. Acutely when they have pain, icing is important. Acutely an anti-inflammatory like Advil or ibuprofen is often helpful. But in the long term, if they want to be involved in an exercise program, it really involves balancing the mechanics of their knee and it involves optimizing the alignment of their foot. If they continue to be active, because one part of the kneecap is bearing more weight than it should, we will see some breakdown of that articular cartilage on the back of the patella, and we will see potentially the development of arthritis down the road, where that white, smooth, shiny surface wears away. So it is important to get it treated, and not only to lead an active lifestyle, but also to prevent arthritis. In some cases, we do surgical intervention. It's not common, but I would probably say 1 out of 50 or 1 out of 100 people, we might end up doing an arthroscopy and smoothing down the back of the kneecap, or we might end up doing a procedure to manually reposition the kneecap so that the kneecap will in fact stay in the middle of the groove.
Definition: The Patellofemoral syndrome, also called consolidation patellar, is characterized by insidious anterior knee pain, produced by fission of the cartilage that cover the patellar, engage the femur and tibia. Several risk factors contribute to its appearance, and if they are not entered correctly, it can generate a connective of the injury. This pathology is very common on runners and young people. However, the incidence and prevalence is 2 to 3 times higher in women compared to men. This significant that is due to the biomechanical difference beyond gender.
Hey guys, it's Marshall and Mike from PhysioU, and today for the Mentoring Minute, we're going to stick with the knee, and this time we're talking about patellofemoral pain. It's a very common condition we see in the clinic. When we talk about patellofemoral pain syndrome, a really good way to assess for it is either doing a step down or a squat. So today, we'll have Dr. Wong go ahead and do a squat. I'll do 2 legs, it's a little easier to change it first. Do a 2-legged squat. Now, if they don't have any pain or you don't see any dysfunction, we can always progress it to a single limb. But here, if you see his knee kind of diving in, so femoral adduction into rotation, if that's painful, we want to change that. So what I'm going to do is, when you squat down this time, kind of push your leg out into my hands. Don't let it dive in. I'll kind of guide you. And see if that changes his pain. Right? We're looking to see if we can control the femur, does that change his knee pain? Right? There's another camp that says, well, how about if we can control the patella? Maybe it's a patellotrachy problem. So adding either a lateral or medial glide, have them squat again, does that change their pain? If it does, there's good articles that talk about taping the patella to allow them to exercise and get stronger, to build up their muscles, not necessarily just taping alone. Now, if we go back to the femur control, well, let's say he got better with the squat, kind of giving him feedback to push out, right? Well, we want to look at glute strength, right? There's a lot of articles that talk about what are the best ways to predict femoral internal rotation, and really glute max endurance over a table was shown to be the best predictor, as we see here. When it comes down to strengthening, there's articles that talk about, are we going to work on strength or are we going to work on control? If we're working on strength, research shows the best exercise for the highest EMG for glute median glute max is a single limb squat. As we know, patients with patellofemoral pain, it's really hard for them to do a single limb squat. It's painful, they don't have the best control, so sometimes we have to start at a lower level. And that's where our clams with the band, sideline hip abduction, single limb bridges, are great ways to start, and then progressing to the double limb and single limb squat. Now, if we move to the control part, there's articles that talk about using visual feedback. So with a mirror here, Mike's going to work on a single limb squat. Let's just do mini squats. Okay? And they had patients only perform 2 weeks of verbal cues, right? And the cues were push your knee out, don't let your knee dive in, and they had a lot of them do these running on a treadmill and just looking at a mirror and then watching videotape of himself. And over the 2 weeks, they slowly decreased how much cueing, so that way the patients could internally try to correct it. And what they found was, after the 2 weeks, improved pain with running, as well as really good carryover to a single limb squat and a step down task. So the idea is, do we want to work on strengthening? If they don't have enough strength, yes, we have to work on strengthening. But if they have it, maybe we just need to work on the control aspect of it. All right, hope you guys enjoyed the Mentoring Minute. And again, change that squat. Is it more femur control versus patellar? And then is it more strength versus control, knowing that we know how to treat for both? Take care, guys.
Pros and cons. The pain can is defined between the following: good at or down strength, kneeling or squatting, sitting with one on a bend for long periods. Certain measures can help prevent pains, maintain strength, think about alignment and techniques, loss total extra prone, perform work with exerciser. Insurance price in Ecuador. In Ecuador, there are people who suffer from the patellofemoral syndrome. Only there is no figure which reveals the number of people who suffer. They are students which were carried out the thesis. One of the students was carried out in Quito at the Pablo Suarez Hospital in February, in which a group of people of different ages suffering from the pathologies can be observed.
In this video, I'm going to give a description of what patellofemoral pain syndrome is and if and how we can diagnose it. Hi and welcome back to Physio Tutors. Patellofemoral pain syndrome, or PFPS, typically refers to anterior knee pain usually occurring during activities such as running, squatting, or walking up and down stairs. Patients of all age categories are affected, and the condition can persist for multiple years in up to 60% of cases. So what is causing the pain? Loading of the patellofemoral joint during weight-bearing activities on a flexed knee is thought to be altered due to various reasons, leading to pain. One hypothesis is abnormal patellofemoral joint alignment and morphology of the trochlea. Consequently, the patella can't track smoothly up and down, which over time can cause irritation of the joint surfaces and trigger nociception. Secondly, Muscle weakness of the quadriceps and glutes is a potential risk factor associated with PFPS. This is because poor strength and function in the quads will influence how the patella tracks in the trochlea and how load is distributed across the patellofemoral joint. Weak glutes, on the other hand, can alter the lag axis if the femur adopts a more internally rotated position with regards to the tibia, again impairing smooth movement of the patella within the femoral trochlea. On our channel you will find proposed diagnostic clusters for PFPS, but all of them only demonstrate weak clinical value. You can find the clusters by clicking the info icon in the top right corner. Essentially, asking a patient whether they have anterior knee pain while squatting is the best available test to date, as PFPS will be evident in 80% of people with this finding. But PFPS has to be seen as a diagnosis of exclusion, meaning the diagnosis is formed after all other possible pathologies have been excluded. Alright, I just mentioned that you'll diagnose PFPS only after excluding other pathologies, so be sure to check out our knee assessment playlist on the left. A collection of all tests, including evidence and description, can be found in our assessment ebook. Check the first link in the video description or click the icon in the bottom left corner of the screen for more info. Before you leave, make sure you are subscribed to our channel and check out our other social media pages. This was Andreas for Physio Tutors. Thank you for watching and I'll see you next time. Bye.
The first thing to do, as in everything good therapeutic approach, is to present to a good individual assessment, not only examine the part next to the pain, but the person in joints and especially the lower limb, height, knee and core. Highlights the importance of medical and physiotherapeutic evaluations. In clinical evaluation, tests are questions for not being specific for the diagnosis of PFS, which requires a continuous evaluation and therefore a recurrence of objective and consent is necessary. Thank you.